Welcome back to Together We Launch Resiliency podcast. I am your host, licensed clinical social worker, Dr. Elissa Kaplan. I am excited for this podcast because while there are many areas of neurodiversity and special needs children experience, the area we will discuss today is one of the most common of all. There could be multiple children in a class that have this diagnosis, and yet no class or school photo would capture it. It's one that can lead a child to be easily misunderstood. With interventions such as environmental changes and sometimes pharmaceutical assistance, the condition, which is lifelong, can be better managed and interfere less with a child or an individual's ability to achieve their goals. Plus, in some areas of life, this neurodiversity often comes with strengths and attributes that could in some way exceed the capacity of those who are neurotypical in their development. This neurodiversity has been studied widely, even globally. There seems to be a continuum of updates in the medical field, including social work, psychiatry, neurology, and also in the field of education, which helps teachers improve their differential teaching methods. This condition is also started to be discussed more in the fields of employment, relationships, including with family members and friends. What is this interesting developmental condition that crosses all borders of the globe and is found to be able to produce highly capable individuals in all fields, especially with accommodations in play? It is ADHD, Attention Deficit Hyperactivity Disorder. Here to speak with us today is Dr. Beth Rabinovitz and Dr. Shira Ritholtz. They are both psychologists with New York Presbyterian Hospital Behavioral Health Center in White Plains, New York, which offers specialized treatment for ADHD outpatients. Many listeners are parents of children in preschool with kids ages 3 to 5. Explain to parents how an ADHD evaluations and services can add to parents' options to help their child to better understand how to interact with their child, rather than having parents think, maybe my child has this condition, but I'm not really interested in the label. They're afraid of it.
Sure. ADHD stands for Attention Deficit Hyperactivity Disorder, characterized either primarily by inattentive symptoms, hyperactive impulsive symptoms, or a combination of both. There are 9 identified symptoms of inattention and 9 identified symptoms of hyperactivity impulsivity. The research suggests the inattentive symptoms of ADHD do not do a particularly good job at discriminating preschoolers with ADHD, although there's increasing utility as children get closer to age 5 and certainly into the school age and adolescent years. But the hyperactive impulsive symptoms of ADHD do extend down to age 3 and do a fairly good job at discriminating preschoolers with and without ADHD. Research suggests when symptoms of ADHD are identified during the preschool years, they do tend to persist and evolve with an increase in difficulties with attention and organization as kids get older and move into the school age years. Preschoolers who are identified as at risk for ADHD without meeting full diagnostic criteria also have an increased likelihood of being diagnosed with ADHD later on. So a wait and see approach to evaluating ADHD in preschoolers may delay helpful early intervention. The recommended treatment for ADHD is different for preschoolers than for school age children and typically involves more behavioral and psychosocial interventions rather than medication, which is not typically recommended as a first-line treatment in preschool age children.
Is it sometimes recommended as a first-line treatment in older?
Typically, we start with behavioral interventions, even with older children. It depends at what point in the stages of symptom expression and impairment they may come in for evaluation once they're at school age.
How much it maybe disrupts the life of the child, the parent, the school, are factors that also guide treatment or intervention. Is that correct?
Exactly.
Some of the challenges with parents getting the evaluation, they're scared or they're concerned about the label and limits because of it.
Sure. The ideal utility of diagnosis is to be able to characterize a child's behavior in a way that's helpful to communicate to other health professionals, to schools, to understand what interventions might be helpful. It's a shortcut way to be able to say, hey, these are some of the challenges that a child may have. These are ways we know how to help support them. It's really a way of communicating how to help the child.
Yes, I agree. The other thing is by having the evaluation and finding out that if this is the challenge for that child, it might not be a different challenge. It might not be an oppositional challenge. It might not be Some other challenges the child has, it helps narrow down the treatment for schools and parents. Or
Exactly.
is there anything they should fear in an evaluation?
I hope not. We certainly try to be supportive and helpful in understanding a child's behavior, the challenges parents may be experiencing, and guiding and directing parents and children toward the appropriate treatments.
My experience, when in doubt, try it out. Check, have the evaluation. Another fear parents may have is people will blame the parent or think it's a parenting style. ADHD is not at all a parenting style issue.
Absolutely correct. ADHD is a genetic or developmental disorder. It's not something caused by the environment. Behavioral interventions can modify the environment to best support a child with ADHD, helping to teach parents parenting practices to learn how to effectively shape behavior, utilize positive reinforcement. There are behavioral interventions and parenting approaches in treating a child with ADHD, but the parent and the environment does not cause ADHD.
Your outpatient services, they don't begin before age 5?
Our outpatient services at New York Presbyterian begin at age 5. There are other outpatient services available for kids who are younger than age 5. Behavioral interventions for a child who at age 3 or 4 is identified as being diagnosed with ADHD or at risk for ADHD can be helpful even before age 5. And research suggests that the behavioral interventions are most effective in younger children, in preschool age children. There's typically not a reason to wait because behavioral interventions like parent training, parent child interaction therapy can be effective at that young age, helping to shape the child's behavior and make changes in their ability to comply and reduce impulsivity.
Where can parents get that?
As Dr. Rabinovitz mentioned, what you're looking for is somewhere that offers parent training and interventions. You would not be looking for individual therapy or play therapy for that kid. You would really be looking for somewhere that will work with the parents, perhaps with the parents and the child together, to give the parent training on how they can help shape their kids' behavior. A pediatrician is a great place to start, or looking on the internet. What you would be looking for is evidence-based parent interventions for kids with ADHD.
That is helpful for parents to hear because they often think I will just send my child to something, and that might not be the best thing for their child at that age, at that time. What are the chances of misdiagnosis? ADHD has a lot of symptoms of other things.
ADHD can certainly be more difficult to identify in preschool because preschoolers do tend to be more active. Preschool programs can vary in the level of structure and expectation. When there are behavioral concerns outside the realm of typical development, or when a child's behavior may be resulting in social rejection, not being invited to play dates and birthday parties, or a school is saying they're not able to stay in that school because of their behavior, that's when an evaluation can start to become important to facilitate this early intervention. In general, in order to reduce the chance of misdiagnosis, the evaluation should really be a multi-method and multi-informant approach. We evaluate behavior across settings, and we collect behavioral ratings that are validated for preschool populations and ratings that have versions for parents and teachers, a clinical interview with the parents to identify problematic behaviors, how those behaviors may be impacting a child's functioning in their day-to-day life, direct observation of the child in the clinical environment as well. Really, in order to make that diagnosis of ADHD, there should be symptoms present across multiple settings. It's not only seen at home or only seen at school. You had alluded to earlier, the evaluation is also helpful in identifying other things that could look like ADHD, whether it be medical concerns, speech and language concerns, other developmental disorders.
I appreciate the expertise. There comes a time when parents and the child benefit from knowing precisely which strategies to go with. How does the ADHD outpatient setting increase a child's resiliency?
What we can do as outpatient providers is provide knowledge to parents about why their child may be acting a certain way. The parent is able to approach this child with compassion and a mindset that is, I am supporting my child who struggles in this area, rather than with frustration that's so normal for parents to feel when their child has difficulty following directions or paying attention. Step one would be to really help the parent understand their child is not doing these things to frustrate them, as you mentioned before, because they are being oppositional. They really may struggle in certain areas. Parents are empowered in outpatient treatment to have strategies to hone these skills and help this be less difficult for their child, therefore, hopefully, less difficult for the whole family. Empowering the parents and also helping the parent communicate with the school so the kid has supports both at home and at school to help them learn to the best they can.
In summary, parent empowerment is very important to a child's resiliency. The parent now has the language and the understanding to advocate for their child more. As that child grows, you would help with teaching that child how to advocate for themselves and also self-acceptance of the challenges they have.
Absolutely. When the parent has better skills to help manage the child, it's going to help the child learn to self-regulate better. The child will hopefully over time have less difficulties in social situations and school. They will also gain an understanding of why things have been difficult for them. It's because this is how their brain works. There's some wonderful things about that and some difficult things about that. They'll be able to take ownership of their whole self and understand how to self-regulate better.
I appreciate that very much because we can hopefully prevent some episodes of depression or anxiety or children feeling bad about themselves when they don't need.
Absolutely.
There are feelings many parents feel, but they don't want to share. I will go ahead and ask the question that does concern most parents before they have an evaluation or before they decide specifically to not have an evaluation, even when the symptoms and challenges that concern them impact their life. How does the doctors or the clinicians distinguish between this is a lifelong condition they see with a child with ADHD, or is the child just reacting to things in their environment, trauma, a social situation?
As you mentioned, the core difficulties of ADHD are inattention, impulsivity, hyperactivity, and those symptoms may present because of ADHD, but they also, as you alluded to, might present because of factors completely unrelated. Some environmental factors may present as symptoms of ADHD. One example is age within the grade. Research has shown that the relative age of a child compared to his or her peers can actually influence a teacher's opinion of whether this child would meet criteria for ADHD. If a child is a few months behind their peers or closer to the cutoff and the youngest in their grade, what may be developmentally appropriate for them might look quite different from their peers half a year older than them. One thing to think about is, are these child's behaviors typical for the age and developmental stage? Other environmental factors are things like lack of sleep. A child who is not getting enough sleep may have difficulty paying attention. They also may present as overstimulated and hyperactive. A comprehensive understanding of the child's environment at home and the symptom ebb and flow. Are these symptoms consistent, or are they more dependent on a big event that week and things have been extra tough at school? There's also some internal factors that may appear like ADHD, but are better attributed to something else. If a child went through something really scary, a childhood trauma, or a recent death in the family, something really sad or really scary, that child may have difficulty paying attention in school, or they may be acting out in some way because they have a lot going on in their little brain that's preoccupying their attention. That would be really important to rule out.
You brought up all great points because that's exactly why the communication and the understanding between the schools, the parents, the clinicians is so important, and why Together We Launched Resiliency podcasts are so important, because it brings that knowledge together. I wouldn't want somebody to get misdiagnosed if we can help it. This way parents know what to bring to evaluations when they're speaking with teachers, what to share. And teachers can view children and ask parents questions about what's going on at home that might influence the child's behavior. They can even ask them some of the specific questions you mentioned just to help the child. What are some environmental factors that could bring out symptoms of ADHD?
Yeah, we spoke about environmental factors that can present like ADHD, but maybe better attributed to something else. Some things that can exacerbate symptoms in a child who truly does have ADHD are things like school and home environments. Kids with ADHD may do better in a highly structured environment with visual cues and clear expectations. If they're in an environment that doesn't have those things, a clinician can work with the school and work with the parents to increase structure, to increase visual cues, to increase clear expectations so that kid is really set up for success.
One of the most prevalent fears also shared with me by parents whose children may have symptoms of ADHD is fear of medication for the condition. Many parents say, I don't want to have my child evaluated because I don't want my child medicated. They misunderstand or they don't understand the benefits of getting an evaluation. They worry about their child getting a recommendation for medication. Is ADHD medication something parents can be forced to give to their child? Or is it something the doctors can only recommend? Is there a gray area at all around this?
Absolutely not. There is no time a medication will be demanded to be taken by your child or accepted by your family. One thing to keep in mind, as we mentioned before, the first line recommendation is behavioral interventions. In all of these things, in behavioral interventions, in medication recommendations, clinicians are here to collaborate with your family. Something important to keep in mind is that you are the expert on your family and your child. The clinician, the psychiatrist, the psychologist, the social worker, whoever is working with you has expertise in ADHD in general, but you have expertise in your cultural background and your values and your child. You really need to collaborate to share that expertise to make a plan that will work specifically with your family. There is recommendations that can be made. Please speak up to your clinician if it doesn't feel like it would be a fit for your family. That person should be able to say, okay, let's find something that will work best for your family that you're comfortable with.
I know that working with clinicians, a very important piece of what comes out of it, if there's a good fit between the clinician and the parent. If a parent doesn't feel comfortable or has a hard time expressing themselves with a clinician, they might look for another clinician or share that they're having this challenge with that clinician and see if they can collaborate better.
Absolutely. It's a lot of time we ask of families. It's a lot of work. You learn strategies and practice them. If you're not feeling like it's helpful for your child, please speak up and ask your clinician, what's the plan? How can we improve this? I also encourage parents to speak to their clinician about what measures are you using to know if my child is improving. Are you speaking with the teacher? Is this something that we're going to do for a few weeks or a few months? We really encourage parents to make sure that you are aware of the benchmarks and know how it's being measured.
Another common concern parents have is they do not always want schools or teachers to be aware if their child gets a diagnosis. Yet the reality is the child is in the school for 6 hours a day. The information can be beneficial to create a supportive environment and make accommodations so that they can reach their social and emotional and their educational goals. Are parents in control of who receives the medical information?
Absolutely. There are very strict laws under HIPAA that protect confidentiality. Clinicians require a written consent to share any information with outside providers, schools, or anyone about your child. Parents are completely in control of who they share that information with. As a parent, you can withdraw consent. If you felt like it was helpful at one point and you no longer want your clinician working with the school, have that conversation. As you mentioned, your child is in school multiple hours a day. As a parent, you and your clinician can work together to discuss what information you would share with the school. If you would only like selective team members at school to know about the diagnosis, it might be helpful to loop in the school psychologist.
After age 13, children have discretion over who sees their medical records in New York State. How do you think that impacts children and families in getting and accessing services or the diagnosis of ADHD based on what you've seen of kids of that age? Now, I'm working with children in preschool age, but parents think about the future a lot. Maybe you can speak to once that child becomes able to decide who gets to see their medical record.
Every time a clinician is reaching out to a provider, it can be a conversation with the parent, ensuring that the parent still wants that provider to be looped in or that teacher to be looped in. Once a child is 13, they can give assent in order for their information to be shared in addition to that parental consent. Therefore, any sharing of information will only take place after a conversation with the child and the parent together. A clinician will help a teenager to weigh pros and cons of sharing any information, correct any misconceptions that child has. So making it clear that this information will not be shared with their friends or their friends' parents, and explain why it might be helpful to share and empower the child to make that decision in a collaborative way with their parents and clinicians.
There is so much information on the internet and in social media groups. What are some key reasons a parent or a child who may have ADHD ought to seek their own evaluation rather just to rely on that information?
ADHD is really a pretty heterogeneous disorder. It can present really differently, even in different children within the same family. A careful evaluation by a psychiatrist, a neuropsychologist, or another healthcare professional with expertise in diagnosing ADHD can be important in properly identifying behaviors that are associated with ADHD, differentiating whether those behaviors are associated with ADHD or something else. In older children, ADHD can also be associated with other diagnoses, such as anxiety, depression, learning difficulties, which can then contribute to greater difficulties or worsening of the ADHD. When there is a concern about ADHD, we want to identify the appropriate interventions. Information on the internet can be helpful in raising parents' awareness about their child's difficulties and helping to direct them to the appropriate evaluations and intervention services, ultimately an evaluation by someone who's trained to identify the behaviors and other things that go along with those behaviors will be important. Research shows when kids are diagnosed through thorough evaluation, it can also help to inform more specific supports and interventions at school,
including the IEP expressing it and then giving those different strategies we know work for ADHD. There are some evidence-based strategies, even behavioral.
Exactly.
There's so many medications and parents have lots of questions about them.
I'm not a child psychiatrist. As we mentioned, especially in preschool years, the first line treatment would likely be behavioral and parent interventions. That said, there are a handful of medications that do have FDA approval for age range, and a conversation and an ongoing relationship with a child psychiatrist will be helpful to parents to determining if medications would be right for your child. One thing that is often emphasized to parents is that there is no magic pill. Medication might be a helpful part of your child's treatment plan if that's what's recommended by a child psychiatrist, but it will likely work best when accompanied by behavioral and parent intervention.
What I also learned over time is it's a tweaking sometimes of the medication, of the dose, of the right kind for parents if they do end up deciding that route later in life with their child, just to keep that in mind. If you think of it as a chronic condition, as a chronic situation, and realize that even the medications can change over time, that's helpful to just be aware. It just can help manage the symptoms, but the symptoms will probably still be.
Yeah, that ongoing relationship with a psychiatrist is important to decide if any changes need to be made to medication, how other factors may be impacting the efficacy of a certain medication.
Here is a great question. How can schools and behavioral health departments and hospitals work together with families to help increase resiliency, improve learning, and overall help children with ADHD reach their potential in all areas?
It is a great question because it's so important for schools and parents and other treating providers, sometimes a pediatrician, to work together to create a plan for your child. Some ways clinicians can work together include giving psychoeducation to teachers about your particular child's presentation of ADHD, helping those schools and teachers create an environment that might alleviate these symptoms. For example, working with a teacher to understand what's seating placement for a child who is easily distracted, or how and when to help a child take physical breaks throughout the day. Behavior plans can also involve teachers. Any skills that a child is working on at home are also practiced at school. For example, if a child is working on keeping their hands to themselves while at home, teachers can work with a clinician to understand how to effectively prompt for this behavior and reward them in a way that is subtle. Practice in multiple settings can really help a child with ADHD to generalize the skills that they're learning. There's also, as we mentioned before, some more formal ways to involve schools. For example, the CPSC, the Committee on Special Education for Preschoolers. This might include a 504 plan or an IEP. Those are plans that formalize extra support. For example, smaller class size or extended time for certain assignments a child with ADHD might be eligible for.
Many years and many parents fought vigorously for those accommodations and to get IEPs, individual educational plans, and 504s, which is a different kind of individualized plan, into the school systems to help children. It's really important that parents feel empowered. They now have those tools to help them advocate for their specific child. Over your years of working with children and knowing parents and families that help manage this condition, What are some insights you've learned?
Knowledge is power. Don't be scared to learn more and to ask questions. Understanding how your child learns and what challenges he or she might have can help you find the best learning environment for your kid and help them get the right support. One metaphor I like to share is the brain of a child with ADHD is like a symphony orchestra. All of the instruments might be working, your child may have all of their abilities, but the conductor is missing. So they're not in sync and they're not being used at the right time, these different skills and self-regulation strategies. And behavioral, or in some cases, medication intervention can just help you and your family and your child to find that conductor, to help give strategies and skills to use all parts of their brain to their potential. It's nothing to be scared of to ask questions. It is confidential. If you have concerns, if you have questions, if you find yourself Googling, reach out to a professional. Either they will help you find strategies for whatever you're seeing if it's not ADHD, or they can help guide you in through the world of ADHD.
Are there any websites that you would recommend for parents?
You've read quite a number of books you've identified in your questions, but there are definitely a number of interesting books and resources. Some of the main ones we direct parents to is the organization CHAD, Children and Adults with Attention Deficit Hyperactivity Disorder. They have a very helpful website with a variety of different information and articles about ADHD, as well as resources, support groups for parents. Attitude Magazine is another helpful resource for parents. The Child Mind website also has a number of helpful articles that are geared toward parents of children with ADHD across the age range.
I'm sure parents will look into those things as they listen to this podcast. I know it's going to help. Do you have any advice for parents on whether or not to get on a wait list for an evaluation from New York Presbyterian Hospital, ADHD outpatient service?
If you have a concern, there's no harm in making a call. Many clinics don't keep formal wait lists because availability can depend on so many different factors. Even if you've heard, oh, they have a long wait, give a call, find out what that means, what that looks like, when might be the next slot to meet with a clinician. It can never hurt to start the process. If you're told that it might take longer than you had hoped, you can ask your pediatrician if he or she has any other local resources you can reach out to.
Edward Hallowell, MD, said in his book, Delivered from Distraction, the best way to think of ADHD is not as a mental disorder, but as a collection of traits and tendencies that define a way of being in the world. I agree with that with so many neurodiversities, but can you speak to that with ADHD?
It's definitely true. I spoke about so many, not only successful, but creative people who have ADHD, and this energy that a lot of kids with ADHD might have, this ability to think outside the box that all neurodiverse kids, as you mentioned, might have, really may serve them well in life. This can absolutely be a part of something that they are working on, and also that is a huge strength for them.
Yes, I agree with what Dr. Ritholtz said, in that the creativity, the ability to think outside of the box, the energy that can come along with ADHD can certainly serve as a strength for a child. Part of the goal of evaluation and working with a child is to identify what their strengths are and help them to use those strengths, use the things that they shine at to manage the challenges that can come along with the ADHD diagnosis.
ADHD, that's not contagious.
It's
Absolutely.
definitely not contagious. It is, though, something that can be genetic and heritable. Understanding of family history can be really helpful in evaluating ADHD and designing treatment.
Interesting. I did read 80% could be genetic, but many parents grew up in a time when we didn't look at these symptoms as a medical condition. The parent or family members wouldn't even know they have it. If they see their child acting in a way that they might act, it really can be hard for them to consider it's a medical condition. Any thoughts on your experiences?
As part of a evaluation for ADHD, clinicians will ask if there's a known family history, but they also might ask, have you ever struggled with this? What was school like for you as a kid? They may ask the parent. Even if a parent never got a formal diagnosis, we do encourage parents to share, oh yeah, paying attention was super hard for me, or whatever it may be. That can really inform a family history, even in absence of a formal diagnosis.
Their sharing their history can actually help their child. Sometimes stigma gets eliminated by society, becoming more knowledgeable about people who have the condition and become successful in society's eyes. This is one way culture norms change. Each person with ADHD is an individual. It's important that I also share, I'm not saying that every child that has ADHD is going to do what another person with ADHD does. I've heard that the CEO of JetBlue Airlines may have it, and that Michael Phelps, the famous swimmer, also said to have it. Can you share some other well-known people who have this condition, or even job positions of people who've had it? Parents can understand the true lack of limits to the potential a diagnosis alone means. The diagnosis itself is not a limit to their child's potential.
Absolutely correct. I've personally worked with people with ADHD who have gone on to go to Ivy League schools, to work for the government, really any position you can imagine. It has not limited them. You are correct. Many celebrities have spoken openly about their ADHD. Adam Levine, Justin Timberlake come to mind. There's politicians, there's athletes. You mentioned Michael Phelps. Simone Biles also is known to have spoken out about her ADHD and achieved tremendous amounts of success despite this. There are entrepreneurs who have ADHD. Bill Gates has spoken. He has had symptoms of ADHD and struggled with that throughout his childhood. There is absolutely no limits, and helping your child understand how their brain works and how they best learn will help them reach any goals and hopefully obtain whatever success they want to despite ADHD.
Thank you. That was so helpful. Everyone's success in life is different. What makes each person happy is different. One person can be miserable doing the same thing that another person finds a lot of joy in. Letting your child develop into the full person that they can be, the mission of Together We Launch Resiliency. Thank you for joining us today, Dr. Shira Ritholtz and Dr. Beth Rabinovitz.